Bonjour à toutes et à tous, j'espère que vous allez bien. Je vous remercie infiniment d'être avec nous cet avant-midi. Je m'appelle Pierre-Luc Béziel, je suis professeur à la faculté de droit de l'Université Laval et je suis titulaire de la Chaire de recherche du Canada sur la protection et la valorisation des données, la Chaire DOSA. Alors, le mandat de la Chaire, c'est d'étudier la manière dont on peut valoriser les données de santé tout en s'assurant qu'on respecte les attentes des patients et des patients en matière de protection des données de santé. Donc, on organise une série d'événements pour étudier justement la manière dont on peut valoriser et protéger les données de santé. La conférence d'aujourd'hui est la troisième d'un cycle de 4 conférences où on s'intéresse à la protection et à la valorisation des données de santé dans une perspective plus internationale. Alors, dans le cadre du cycle jusqu'à maintenant, on est allé en Belgique, on est allé en Afrique du Sud, et aujourd'hui, on revient plus près de chez nous. On va en Ontario pour discuter du projet Target Kids, qui est mené à l'hôpital Sick Kids de Toronto. Je vais faire la transition vers l'anglais pour le reste de la conférence. Donc, hi and welcome everybody to this third installment of our series of web conferences on health data in health research. Today, we are extremely pleased to welcome Xuedi Li. Xuedi is an epidemiologist with the Target Kids Research Network at Sick Kids. She will be discussing some of her project where she's been involved to improve child health outcomes and explain how her teams gather, uses, and protects health data. So we are looking at a presentation of 45 minutes. And then we have some time for some question and discussion also. So, Xuedi, thank you very much for being with us this morning. The floor is all yours.
Thank you so much, Professor Pierre-Luc, for your kind introductions. And thank you and Marie-Pierre for inviting me to this wonderful conference. I really appreciate this opportunity. So as Pierre-Luc said, I am an epidemiologist at the Hospital for Sick Children in Toronto, Canada, and I'm very excited to share with you our research group called Target Kids, a primary care practice-based research network in Canada. And I'm very excited to share with you our work, our research using child health data, as well as linked data sets to improve children's health and well-being. So for today's talk, I'm hoping to go over briefly who we are, what we do, what data do we collect, what data linkages do we have, and what do we do with our data, so our research and our impact on health, education, and other health outcomes. So first of all, I want to briefly go over who we are. So our overview of our research group, our team, how we recruit our patients, our participants, our network, parent partners, and some milestones and impact. So Target Kids, the applied research group for kids, is Canada's largest primary care practice-based research network for children. So this is our website. So we are a longitudinal research cohort following young, healthy children and their families from birth to adolescence. So we launched this cohort in 2008. It's still ongoing. It's an open cohort. And we followed over 13,000 children since 2008. And our goals include to maximize the value of children's data through linkage across sectors, to build a state-of-the-art child cohort through a primary care practice-based research network, to learn more about children's health and well-being as they grow and develop, to test promising interventions to raise healthy children, and to implement new knowledge to help all children reach their full potential. So really, the overall goal is to improve the health of Canadians through early prevention and interventions. So Target Kids, our research group is based out of Sick Kids, so the Hospital for Sick Children, and St. Michael's Hospital in Toronto. So Sick Kids Hospital is Canada's most research-intensive hospital. It is ranked the world's #1 children's hospital last year. Our co-PI, Dr. Catherine Birkin, is a pediatrician and a senior scientist at Sick Kids. Another co-PI, Dr. Jonathan McGuire, is based at St. Michael's Hospital. So It's a large urban hospital serving Toronto's downtown communities and beyond. And the Li Ka-shing Knowledge Institute at St. Michael's Hospital, they provide database management and operations for target kids. So our team consists of investigators, so Dr. Catherine Burton and Dr. Jonathan McGuire, both pediatricians and professors at the University of Toronto. We also have multiple collaborating investigators across multiple institutions. So we have researchers from McMaster University, Queen's University, Toronto Metropolitan University in Ontario. We also have professors in UBC and also researchers and pediatricians from McGill. So this is our operations research staff, including clinical research project coordinators, managers, communication advisors, analysts, and database operations specialists. We also have our site-based research staff. So these are our research assistants at each Target Kids participating site. I will talk more about our site in a few moments. We also have multiple trainees, students, and researchers across different levels. So summer students, master students, PhD students, postdocs, as well as medical school students. These are our wonderful parent partners. So I will also talk a little bit more about them later. We also have our youth partner researchers working with us on several youth-focused projects. So that's our team. It's a very big team. So how do we recruit our participants? So we are a primary care practice-based cohort. So we recruit young children from their family doctors or their pediatricians' offices at their regularly scheduled well-child visits. So we now have 13 large clinics across Ontario, mainly in the Greater Toronto area. And we have a research assistant at each clinic. So every time the child comes in for a well-child visit, the research assistant will approach the family, get the consent, and collect all the data. We're now expanding our recruitment to community health centers and school-based clinics to increase diversity of our sample and the generalizability of our findings. So I'll briefly go over our enrollment process. So research assistant based in the clinic, they will, before the child's well-child visit, they will identify families to be approached based on the schedule of upcoming visits. And the research assistant would send out letters with a brief description of the study 2 weeks prior to child's visit to the clinic. And they will do remote enrollment. So the introduction letter will be sent out to eligible parents by email with brief description of the study. And the research assistant will contact those families who express interest. And during the child's actual visit, the research assistant would meet and greet the family and explain the goals of Target Kids of the study, and we'll explain the family involvement if they choose to participate. And the research assistant will answer any questions the family might have. And if the family agrees to participate, the research assistant will explain the parents' consent form and all questionnaires. And then the family will sign the consent form and are officially enrolled in Target Kids. So in our clinic sites, our research assistants introduce Target Kids, use of various resources like brochures, short scripts, and introductory emails. We also have some child-friendly materials like word search puzzles, coloring pages, and storybooks. This is a very cute storybook and very colorful. I really like it. This is developed by 2 of our summer students. So this book is about how the kids are going to be participating in the Target Kids research procedures. So really, really cute and really fun. We also make sure our participants are well compensated for their time and participation. So we give out gift cards for enrollment, completion of blood work, and completion of our annual survey. So this is the network of participating clinics currently participating in Target Kids. So over 10 large group practices and over 60 participating physicians, so pediatricians or family doctors, mainly around the Greater Toronto area, but also in Kingston, Ontario, as well as we're right now expanding to Alberta. So we're working with a pediatric group in Edmonton, as well as we're collaborating with a site in Richmond, British Columbia. So Target Kids, as I mentioned before, we're also expanding to community healthcare centers or CHCs. So community health centers in Ontario is basically, I did a quick research online, is the CLSC, the local community service centers in Quebec. They are not-for-profit organizations, primarily focused on providing healthcare to populations who have traditionally faced barriers accessing health services, including families living on low income, new immigrants, those with complex mental health issues, and individuals who do not have health insurance. So we are now collaborating with 10 community health centers across Ontario, and we're trying to implement Target Kids to have a research assistant at each community health centers, and they have all committed to implementing Target Kids into their practice. So it's very exciting. So I want to spend a few minutes talking about our wonderful parent and clinician team, the PACT, so our patient engagement work. So we have established a partnership and advisory team between our researchers and participating parents and families called the PACT. So the goal is really to actively engage our parents and families throughout the research process. So not just at the beginning of, the enrollment, we get your consent, we get your data, and then bye-bye. We don't want to do that. We want to make sure that our parents, our families are actively engaged throughout the research cycle. So we have over 10 active parent advisory members. They're from different families with diverse sociodemographic backgrounds. So they meet quarterly, so they meet regularly online to discuss research priorities. They help us with our study design and our questionnaire design. They also contribute to our study interpretation and knowledge translation. So the PACT, our parents, they've really been instrumental in helping to frame our research priorities. So in 2017, the parents from our PACT set 10 research priorities, so 10 areas that they think were very important and they wanted us to do research in. So here are the number, you can see the different priorities ranging from mental health prevention and screening, physical activity, daycare attendance, obesity prevention, nutrition, screen time, developmental delay, and parental stress. So here are the number of publications and the total number of citations for each priority area. So in March 2023, we reviewed our progress, tracking our research endeavors against these priorities. And from the 104 papers we've published since 2017, 103 linked back to the parent priorities, with the one lending as a precursor to set the stage for future research. So here are some pictures of our PACT parents participating in conferences. So really, rather than just participants, they are our advisors, really contributing to advice and feedback. There are collaborators and partners that commits to studies and grant applications. They are also mentors, providing support to new PACT members and study teams. So it's truly, truly a wonderful community. And lastly, I want to briefly kind of show you the Target Kids milestones since 2008, since we launched in 2008. So we enrolled our first child in 2008, and by the time of 2013, we have 5,000 children enrolled. And in 2014, we linked our data with ICES, which I will mention in a few slides. So the health administrative data sets in ICES. We established the PACT, the Parent Advisory Team, in 2017. And in 2020, we all know what happened. We pivoted to remote enrollment, and we launched our COVID-19 study to look at COVID-19 infection, vaccination, as well as public health adherence measures in children and families. In 2023, we have over 12,000 children enrolled, and we established our linkage with the EQAO data. So I'll briefly talk about EQAO in a few slides. And in 2024, as I mentioned before, we established our partnerships with community health centers. And last year, we successfully launched our health and education forum, as we're collaborating with education researchers as well as educators. So it's been a good 17 years. So here are some of the Target Kids impact in numbers. So we have enrolled over 13,000 children. We've published over 150 publications. We have over 10 million data points. We have over 10 active PACT parent members. We've awarded over 10 million grants, mainly from CIHR, in the last 5 years. We have over 10 randomized controlled trials within this longitudinal cohort, which I will talk about in the end. We've collaborated with over 40 investigators. We've conducted over 20 observational studies, and we've supported over 70 students and trainees since 2008. So I am very proud of this group. So now moving on, I want to talk briefly about our data collection, including the routine data collection, and I want to emphasize on our school readiness data, which is the early development instrument data collection. So since 2008, at each well-child visit, parents are invited to complete an age-specific standardized questionnaire, including questions on sociodemographic information, nutrition and eating behaviors, screen time, physical activity, and sleep, child developmental screening, child and parent mental health and well-being, child daycare and school participation, as well as service utilization. So in addition to this questionnaire data, anthropometric data is also measured by our trained research assistant at each site. So that include child and parent height, weight, and waist circumference. We also measure child and parent blood pressure. In addition, children are invited to participate in non-fasting blood sample collection. So we have lab data on lipids, glucose, micronutrients such as iron and vitamin D status, as well as inflammatory markers. So we have multiple domains in our questionnaires using multiple validated tools. So this is a pretty, I guess, this is a pretty clinical slide. So I just want to show that we have internationally validated and standardized tools to measure these domains, including child mental health, development, nutrition, health behaviors, as well as parenting and parent mental health. So for the next few slides, I want to talk a little bit about our early development instrument data, so the EDI data. So it's the equivalent of this l'instrument de mesure du développement de la petite enfance, excuse my French, in Quebec. So I did a quick research online. This survey, the Quebec Survey of Child Development in Kindergarten, is a mandatory survey in Quebec since 2017. So in fact, this early development instrument is measured or administered nationally and internationally as a validated instrument to measure a child's developmental readiness to start school in 5 developmental domains. So this is a teacher-completed questionnaire, and it was developed by the Offers Center for Child Studies at McMaster University. The code developer of this tool, Dr. Magdalena Janis, is our collaborator on this study. So it's developed for the use for kindergarten children aged 4 to 6 years. So we've started collecting the EDI data since 2017, and across 15 school boards and 315 schools in Ontario, we have completed EDI data on over 1,400 Target Kids children. And using that EDI data, as well as our regularly collected health data, we were able to link several factors, including childhood obesity, growth, and lifestyle factors with this EDI data. So here I want to highlight some key EDI publications. So in this publication, we showed that higher early nutritional risk, so in dietary intake and eating behaviors, were associated with 4 times lower school readiness in kindergarten children. So this publication, we showed that higher early screen time in kindergarten children was associated with lower school readiness as measured by the EDI. And we also showed that meeting the Canadian 24-hour movement guidelines, so this physical activity, sleep, and screen time guidelines, was associated with better school readiness in kindergarten children. We also linked overweight and obesity, so through using child height and weight with EDI data, and we showed that children living with overweight and obesity were associated with lower school readiness, but we did not find growth rates or growth trajectories to be associated with school readiness as measured by the EDI. So that's these are the key publications using the EDI data. And now moving on, I want to highlight 2 external data linkage work that we've been doing. One is with the EQAO education data, and another one with the ICS health and administrative data. So first of all, I want to talk about our linkage work with the Education Quality and Accountability Office, or the EQAO, in Ontario. So in Ontario, the province-wide assessment, education assessment of standardized tests to measure academic achievement, they are administered by an organization called the EQAO. So it's like the ministerial examinations in Quebec. So each province has their own standardized assessments. So in Ontario, the EQAO is a Crown agency of the Government of Ontario responsible for monitoring the quality and providing accountability for Ontario's public-funded education system. And since 1996, EQO has measured and monitored students' academic achievement through province-wide standardized tests in reading, writing, and math in grades 3, 6, 9, and 10. So these tests are conducted annually in all Ontario school boards, and they are grounded in the Ontario curriculum. So what do they assess? So they administer tests in grade 3 and 6 for reading, writing, and math. In grade 9, they have math test, and in grade 10, they have the Ontario Secondary School Literacy Test, the OSSLT, which is a graduation requirement. So the EQO employs rigorous test development and process, and to make sure the validity, reliability, and consistency in year-to-year assessments. And the test results are reported as levels of achievement. So the higher the level, the better the academic achievement. So in addition to the EQAO standardized testing data, EQAO also collect student questionnaire data and demographics data. So each year after the completion of the standardized tests, EQAO administers a student questionnaire with questions on a variety of topics, including learning, academic self-perception, confidence, home and school environments, and collaboration at school. So they have questions or statements like, I'm good at math, I like to read, I'm a good writer, I feel like that I belong at school, and the students will answer whether they agree, disagree, or strongly agree. So these psychosocial data, it's very, very important and very helpful. We also have in the EQAO records student demographics data, including the IEP, so the individual education plan status, which is the plan de intervention, the PI in Quebec. We also have giftedness and disability exceptionality data, first language data, ESLs, English language as a second language data, and French immersion enrollment data. So lots and lots of data from EQAO. So Target Kids has an established partnership and a signed data sharing agreement with EQAO. Since 2012, Target Kids families have provided consent to access their children's standardized test results, as well as student questionnaires and records for grade 3 and grade 6. So we have over 34,000 Target Kids children with linked grade 3 EQAO data and over 2,200 children with linked grade 6 EQAO data. So I want to spend the next few minutes talking about our recent publications on child screen time and EQAO results. This is kind of our first publication using the linked EQAO data. So really linking our health data with the EQAO's education data. So this paper, the main goal or objective was to determine if child screen time, including total screen time, TV digital media time, and video game time, were associated with reading, writing, and math achievement as measured by the EQAO test in grade 3 and grade 6. So just to give you a brief kind of context of screen time in children, it's a very big topic right now. Everyone's talking about screen time. The parents, researchers, educators, they're all worried about excessive use of screen use. But despite that, we know children nowadays, screens are everywhere. Although current guidelines like the Canadian Pediatric Society guidelines recommend screen use not to be used under the age of 2 and limit screen time to less than an hour per day for 2 to 5 years. But still, screens are everywhere. We know that in screen time research, total screen time is an important measure of child health behaviors. but also types of screen time matter because not all screens are equal. And we have lots and lots of research, systematic reviews showing that excessive screen time is linked to negative health, mental health, and education outcomes in children. So for this study, as I mentioned, academic achievement is an important indicator of education success, and the mechanisms of child screen time linking academic achievement could be due to the displacement of physical activity and sleep. Screen time could alter brain structure with excessive use. It could really impede social development due to distractions. On the other hand, screen time might enhance learning through access to resources and technologies. But most studies were really cross-sectional and they focused on older children and youth. So for this study, we conducted a prospective cohort study looking at children 0 to 12 years, recruited from Chaire Kids with linked EQAO data. And we looked at data across 15 years, so since 2008. And we have over 3,300 grade 3 children, over 2,000 grade 6 children with both parent-reported screen time data and linked EQAO test results. So what did we find? So after adjusting for important covariates, including child age, sex, ethnicity, maternal education, family income, year of test, as well as individual education plan status, each additional hour per day of child screen time was associated with 10% lower odds of achieving a higher level in reading and math in grade 3 and grade 6. So really higher parent-reported child screen time, lower academic achievement in elementary school. So really, this study really, underscored the importance of developing and testing targeted early interventions to really reduce overall screen time exposure, to improve academic achievement and education outcomes in elementary school. That we think it's very important that healthcare providers, schools, teachers, parents, and children, they all work together to build a balanced daily routine that include, sleep, physical activity, and play, especially early on, to have really a realistic, family media plan to support healthy screen use. And it really shows that cross-sector collaboration is important. Health and education sectors cannot work in silos. We must work together and leverage data linkages to drive meaningful impact. So this study received wide media coverage. So Dr. Catherine Burkin, the PI of this study, she was interviewed by the CBC, the Nationals. Our research was featured on, I think, Toronto Star, the CBC news article, and CP24, and many media outlets around the world. So I think it's a very important work looking at, the impact of children's screen time across over a decade, across 15 years. So I want to briefly talk about our current Chaire Kids projects using the EQAO data. So we are currently examining early child nutritional risk, as well as so including dietary intake and eating behaviors, how that links to academic achievement by the EQAO. We are also evaluating the Canada's National School Food Program, so the federally funded school food program launched in 2024, and how that school food program impact children's health and school outcomes, including the EQO tests. And we are also examining early childhood growth, including underweight, overweight, and obesity, as well as the psychosocial well-being and academic self-concept using the EQO school questionnaire data. So lots and lots of projects with this data linkage. So lastly, before moving on to the ICES data linkage, I want to show briefly last year in October, our team had the pleasure of hosting a health and education forum. So it's a collaborative gathering that brought together teachers, educators, healthcare professionals, and researchers, including representatives from 5 school boards across Ontario and the former Deputy Minister of Education in Ontario. So this forum was, really an opportunity to share our research, learn more about the challenges in the education system, and just to explore our shared priorities and how we can, build stronger partnerships to better support children's health, learning, and overall well-being. So that is our linkage with the EQAO. So moving on, I want to talk about our work with the ICES, so Health Administrative Data Set. So for those of you who don't know, ICES is an independent, not-for-profit research institute funded by the Ontario Ministry of Health. So it is basically like an inventory of coded and linkable healthcare data sets. So it really includes much of the public-funded administrative health services across the Ontario population. So health service records for almost 21 million people. So because of the legal status of ICS under Ontario's Personal Health Information Privacy Act and the Coroners Act, ICS is allowed to collect and analyze healthcare and demographic data without requiring individual participant consent for evaluating and monitoring the health system in Ontario for improvement and for public health. So there are multiple data sets available at ICES. So mostly health administrative data, so including physician visits, emergency department visits, Ontario drug benefit claims, electronic medical records, hospitalizations, narcotic use, so lots and lots of service use data. There are also some non-administrative health-related data sets like clinical registries and health survey data. And there are also non-health related data like demographics, federal immigration data, and neighborhood income level. So their data dictionary is available online, it's publicly available. So you can see there are multiple data sets, mainly health service utilization data, diagnosis data. So it's really just so much data within ICS. So Tari Kids, within Tari Kids Children and Families, consent to have their data linked to ICS holdings and included in analysis. So data from children and Tari Kids, they were deterministically linked using their individual OHIP numbers. And we have several ongoing Tari Kids projects using ICS linked data, so including factors associated with COVID-19 PCR testing and infection. We also are looking at maternal preconception health, so the diagnosis of diabetes and hypertension prior to giving birth, and that's ICS data as well as their link to child health outcomes. So for this slide, I want to briefly go over kind of our data management and operation efforts. So we have a wonderful data operations and management team. So here are our team members at St. Michael's Hospital. So all data are securely managed and stored within the RedCap platform at St. Michael's Hospital in accordance with provincial and federal privacy legislation. And we have a dedicated team to safeguard data security, integrity, and governance across the full data cycle. And Target Kids is, of course, approved by Research Ethics Boards at SickKids and St. Michael's Hospital. So informed consent includes transparent communication about data collection, use, storage, linkage, and sharing. And participants are clearly informed of their rights and the implications of data linkage. So lastly, I want to talk about our key research areas, some of the randomized controlled trials within our cohort, and lastly, our knowledge translation or mobilization efforts. So some of our key research areas include, as you probably have seen from the publication I mentioned, childhood growth and obesity prevention, maternal and child health, child development, school readiness using the EDI data, COVID-19 and public health measures because we have access to infection and vaccination data, mental health, cardiometabolic risk because we have lab data including glucose, lipids, as well as child blood pressure. We also have data on nutrition and eating behaviors, dietary intake, child and parent mental health, childcare and school outcomes, so learning outcomes, daycare participation, screen time, physical activity and sleep, as well as policy evaluation. So we are now evaluating the Canada-wide early daycare policy, the federal daycare policy, childcare policy on child health outcomes, as well as the Canadian Dental Care Plan, the CDCP, on children's oral health, because we also collect parent-reported oral health data over time. So I want to also mention briefly about our trials within cohorts study. So Target Kids, we are an open longitudinal cohort study, but so observational study, observational data. But within our cohort, there are several randomized controlled trials happening. So all the trial participants, they are enrolled in Target Kids, and their data collection provides outcome measures. So each participants for each trial, they're enrolled in unique trial database, and all the data collection are centralized through REDCap. So participant data is linked between trials to reduce burden. So they don't answer questionnaires multiple times. So they allow comparative evaluation. So I want to highlight three current randomized controlled trials happening within the Target Kids cohort. The first one is called the Nourish. So this is a randomized controlled trials assessing the intervention of having a lactation consultant and as well as an access to a center-based childcare navigator before the age 1 and how that will impact children's health outcomes. So this is currently ongoing. Dr. Jonathan McGuire is the PI for this trial. Another trial is called Comfort. So because we know from observational studies, we know that higher percent fat cow's milk was associated with lower childhood adiposity. So we are currently doing these randomized controlled trials to look at the effect of whole versus reduced fat cow's milk on growth in young children. So lastly, this Parents Together trial, this is the purpose of the trial is to look at how an 8-week parenting program delivered by a public health nurse, how that impact children's health behaviors such as healthy eating, screen time, nutrition, sleep in young children. So this is currently led by Dr. Catherine Birkin. And all the trials, they're funded by the CAHR. So lastly, I want to touch on our knowledge mobilization work. So it's really important that we share our research beyond just publications. So if you go to our website, we have lots of resources and, web pages showcasing our work and our knowledge translation work, including conferences. So we participate in multiple pediatric and nutrition conferences. Here are some examples of our posters. We also generate infographics for our parents and for the public. So here are some infographics examples from our EDI study, from our screen time study, as well as some studies on obesity prevention. We also have regular newsletters sent out to our parents and as well as our collaborators. So if you go to our website, we have every 2 months we have our newsletters, and we also have, on our website, featuring our staff member interviews, as well as our ongoing research deliverables and impact. So that's all for kind of a very brief overview of our research and target kids. So what's next? So we hope to continue to strengthen our parent and youth partners to really involve them in our research. We will also keep building community partnerships with schools, with educators, as well as community health centers. We are continuing exploring new collaborations and adapt our recruitment strategies. We are improving our data collection methods to make sure it's feasible, it's flexible, and accessible to all families. And we are currently expanding to Alberta and BC, hopefully to establish a national child health cohort. So that's it. With that, I'd like to acknowledge the entire Target Kids team. So everybody who's involved in the Target Kids Research Network, as well as all the participating families, parents, children, for their time and involvement in our research. So our research would not have been possible without their participation. So thank you for listening. Happy to answer any questions. But there are areas of Target Kids that I am not familiar with. So if I can't answer your question, I'm happy to bring it back to our team and circle back. So really looking forward to discussion, and thank you again for having me.
Thank you very much. Thank you very much, Xuedi. It was a very interesting presentation and really exciting work, and it really shows how it's important to bring data together and link data to produce such exciting research. So do we have questions online? I have tons of them, but I was maybe give the chance to people in the room. So yes, we have one. You can open your mic, or yeah, okay, go ahead.
Hi, thanks for the hi, bonjour. Thanks for the presentation. Can you hear me okay?
Yes.
Yes.
Okay, super. Hi, and sorry for tuning in late. I'm Claire Tsugoulafla. I'm a nutrition researcher at the University of Ottawa, and I collaborate with Jessica Omen, so I'm familiar with the cohort a little bit. My work looks at sort of school childhood obesity prevention and settings-based health promotion, so childcare and schools. So I'm very interested in your cohort. I'm just wondering if you could speak to the regional sampling approaches for target kids again, because I'm just curious as to whether and maybe you said this at the beginning of your presentation, but is it mostly people from the GTA area, or do you also have kids from, northeastern, Eastern Ontario, and what is the proportion of kids from French minority populations in Ontario, specifically, if you know that?
Thank you so much. Thank you, Claire, for your question. And so glad to hear that you collaborate with Dr. Jessica Oman. Jessica is amazing, and she's doing some nutrition-related work here in Terry Kids. So maybe I'll reshare my screen so that better answers your questions. So this our primary care network mainly operates in the Greater Toronto area. So we have mostly clinics in Toronto, Etobicoke, Mississauga, Scarborough. We have one site in Kingston, and we're currently expanding to BC and Alberta. So I'm not too sure about the percentage of French minority children in our group. So I need to look upon that. But we are currently expanding to community health centers across Ontario. And that includes, so currently 10 CHCs have committed to implementing Terry Kids into their practice. And I believe that includes one Francophone community health center and several community health centers in the Northern Ontario. So that's to my knowledge. Does that answer your question?
Yes. So all of your tools, are they in English, or do you have also French validation or French tools?
I'm not entirely sure. I think we should have both in English and French, because briefly, I think we had a site actually in Montreal. So I'm sure the tools, they have to be translated in French, but I'm not 100% sure.
Super. Thank you.
Thank you.
Thank you very much. We have a question from Lynn Moore.
Yes, thanks very much for the presentation. That's a fabulous project. I had a question about what strategies you use to make the data collection as sustainable and low cost as possible. I actually work in pediatric trauma, and we're looking at how we can collect long-term data on patients that are hospitalised following trauma using, for example, patient portals or and self-administered questionnaires.
Great question. Thank you so much. Attrition, participation, retention, it's a challenge, it's a struggle in this field, like for everybody. So we actually, I think about 3 years ago, we did like we basically did an analysis within our cohort to look at factors associated with research participation. We looked at actual retention since 2008 across different sites, and we looked at the sociodemographic factors associated with participation, and of course, several factors, including income, maternal education status, as well as maybe being an immigrant or not having English as their primary language, first language. These sociodemographic characteristics, they are linked to research participation in Terry Kids. So we developed several strategies really targeting these findings. One of the strategies is really to make sure they're well compensated. So really having gift cards, giving out gift cards for each, the completion of each survey, the annual survey, as well as blood work, as well as enrollment. And we developed many child-friendly materials, the one I just shared, like the storybook, the coloring, like the puzzle, the cartoons. Like we tried to develop these child-friendly material to improve participation. And we make sure our research assistant, they have, longstanding, trusting relationships with the family. And we make sure the research assistant, they undergo EDI training to make sure they represent the community that they serve. So it's still, we are still improving, but here are some of our strategies to date.
Thank you.
Thank you.
Great, thank you. Do we have other questions online or in the room?
Mm-hmm.
No? So I'll ask a few questions also, because I may, well, I'm a privacy law scholar, so I just want to bring it back to how you handle the data that you collect. So as you said, you have tons of data that you collect. It's very sensitive data, obviously from both the child, but also the parents, and you link those data to other data sets from ISIS, for example, that type of stuff, the examples that you gave. So I just wanted, if you can speak a little bit on the data governance structure within the project. So is it the central data bank that every researchers within the group is vetted in a sense and can access the data structure? Or is there access that are limited in terms of what type of project do you conduct? Or do you have to be approved to access the data from within also? Or is it more like an ISIS structure where you can use the data that you need within the structure? It's a project by project basis. So this is the first question. And the second one is more related to the parents and that your PACT team and the work that you guys are doing with the parents also, and the data subjects in general. So it's important, as you said, and the previous question was also a little bit on this point, to engage with the data subject, whether the kids or the parents, to keep them engaged and participating within the project to access the data, but also to maintain the trust. And so the reflex to give back and to continue to give the data, and so that they do not leave the project. I was wondering if those parents, and even if the kids, what's their perception of privacy? Do they have any concerns, or do they ask questions? Is it something that they really see as important, or are they really focused on the valorisation impact and the research that you guys are conducting? Or when you sign, for example, the consent form or that type of stuff, do they express precise and deep concern about their privacy within the group? Do they ask questions? So the first part was more within the group who access the data, and then the perception maybe of the kids and the parents of their own privacy within the project.
That two great questions, Pierre-Luc. So to answer your first question, we do have a very standardized SOP of accessing the data here in Target Kids. So as I mentioned, all the data are essentially securely managed and stored within the RECAP platform at St. Michael's Hospital, in accordance with provincial and federal legislations. And we have a dedicated data management and operation teams to safeguard the data security and governance across the full data cycle. So in order to access the data, for example, I do not have, let's say tomorrow, I want to analyze, I don't know, nutrition and EQAO data. I can't just get the data. Like I, as an epidemiologist and analyst with Chaire Kids, I don't have access to that data. So only the data operation team and our statistician, our biostatistician, they have access to the database, so they can pull the data. So in order to get the data cuts to analyze for your project, you have to go through a very standardized procedure. So we call that the DCP procedure, the data creation plan and analysis procedure. So let's say I want to, I don't know, analyze nutrition and EQAO data. So I would need to first prepare a data creation and analysis plan, a very standardized document, indicating what variables you would like, what's the analysis plan, what's the timeline, what's the, so who's on your team. And then I will submit that DCP, that plan, to the Target Kids Scientific Review Committee. And then I will need to do a presentation, a scientific DCP presentation at our Target Kids group meeting in order to get approval. And that DCP, that data creation plan, needs to be approved by at least 2 scientific reviewers within the Target Kids, so within the Target Kids Scientific Committee. So once the DCP is approved, that data creation plan, the DCP, will be sent to our statistician to get data cut. So the statistician will cut the data based on the variables indicated on the DCP. And then you will, like, I will receive the data securely, transferred to me securely, the data, and then I will analyze, and I will, perform analysis, interpret the data findings, and in the end, we'll need to upload, all our finished data analysis, the code and everything, back to a central folder stored so on SharePoint. So it's a very standardized procedure. External Target Kids people can also apply, for Target Kids data through this DCP process. But internally, even let's say RPI, Dr. Catherine Birkin, if she wants to have like a data, she needs to go through the same procedures. She cannot just have the data pulled for her. And there is a fee associated with each data cut. So that's basically the, and I believe every month, it's either monthly or quarterly, we have a data management meeting, an operation meeting to talk about, data sharing, to go over the DCP process, just to make sure everything's standardized. So does that answer your first question?
Absolutely. And I had a quick follow-up, but I think you answered it also. So external researchers that are not from the project could also go through this project and this process and with the two reviewers. And so your data is also accessible to researchers that are not part of the project per se. They just have to go through the same. Okay, that's very interesting.
Correct.
Yes. Yeah. So
yeah, that's why we have like collaborating researchers from McMaster. Like we have researchers doing, maybe an analysis of, data from 4 cohorts, and one of them is Target Kids, and they will access Target Kids data using this DCP process. Of course, they will need to pay like a fee, so they will need to have funding, and to get that data cut. We've also collaborated with, international researchers. So really, the process, we have like a standardized document of this SOP. So yeah.
Yeah, perfect. Great. Thank you very much.
And your second question about the parents, that's actually a great question, because unfortunately, I don't think I can answer that question around their concerns about privacy, because I'm not involved in, that part of the research cycle. I'm more like, analyzing the data after the data collection. But yeah, I mean, every kind of, before launching any survey or any kind of approach to collect data, we always consult with our parent advisors. For example, as I mentioned in the screen time paper, so right now, the most practical and feasible method to measure child screen time is through parent-reported questionnaire in young children, in a population-based study. But, we want our measurement to be accurate, and we are exploring, objective measures of screen time, child screen time. So, on your iPhone, there's the screen time feature on your settings where it will just show you, for the past week or yesterday, your average screen time. Is it 3 hours per day, 4 hours per day? So we are hoping to kind of pilot this device-based like screen time tracking method in children. So like maybe get a screenshot, I don't know, from the child's phone or tablets or iPads, so we can get like a direct measurement of the child's screen time. But we understand that some parents might not be comfortable with that, some children might not be comfortable with that. So before kind of launching that study, or before putting it in a grant, we met with our PACT members to make sure they're comfortable with this idea, and we received lots of feedback. So yeah, they are very involved in just any kinds of study methods, survey methods, as well as questionnaire development.
Great. And so, and I think also, and I don't want to monopolize the platform, but is there any other questions online or from the room? No. So I think that from a privacy standpoint, what we read often in the literature is that people will give their information, if they trust the person with whom they interact, but also if they see the benefits of sharing the information, the potential outcome in terms of research. So I think that the work that you guys are doing also in terms of knowledge transfer, not just in terms of scientific papers, but also the conferences and not popular science, but make it more accessible to parents, probably goes a long way on that side of maintaining the trust and addressing the privacy issues that people might have, but also to encouraging data sharing on their part. I also have another more specific question, because there was something very interesting for me in your presentation. It was slide 31, so it's very specific.
Yeah.
It was regarding the data sharing agreement that you have with EQAO.
Yeah.
And so you said that you had their data sharing agreement for the data, but it also said somewhere that you had an agreement on a specific algorithm that you used. I was very curious because you just mentioned it and they didn't really explain it. So I was curious as to how within a data sharing agreement for data linking, where you put the algorithm, and so what role does it play, and how does the agreement regulates it? I don't know if it's a clear question, but it was just something that was really interesting for me. It was the first time that I saw algorithm in the data sharing agreement, so I was curious.
Yeah, we basically, for the algorithm, it's pretty simple. We use the kid's first name, last name, and school to determine their the school name. And of course, these informations, they are de-identified when, analysts like me are receiving and analyzing the data. Yeah.
Comment.
Yes, so there's a comment. Yeah, so thank you very much.
Thank you, Claire.
Thank you, Claire. So do we have any other questions? For me, it was perfect.
Maybe a really quick comment about the perception of privacy. You talk about the example of screen time, but like I just had a reflection about the fact that screen time is not that intimate. Like we know we all spend too much time online or on screen, but maybe there's a really sensitive subject that you work on. I don't know, obesity or like specific medical cases that maybe the preoccupation about privacy can be higher in some when it's more unusual or intimate or how you say that in English, like a delay in les retards de croissance, like and so yeah, it was just a reflection that maybe there's like the perception or the precaution are higher depending of the research subject or the health problem concern.
Yeah. Yeah. Absolutely. I understand what you're saying, Marie-Pierre. So yeah, for obesity and, research, it's really important that we do not, contribute to the, weight stigmatization, the bias. I think that's really important. So we are very careful when, conveying our, research messages to our participants to make sure we use, people-friendly language. To do so basically, in addition to measuring, height and weight data and also, waist circumference and cardiometabolic risk data, we also collect data on, just psychosocial, just for example, the everyday discrimination scale, that's part of our data collection. Any, experience in terms of, weight stigmatization. We collect that data just to make sure we cover, not only, the physical health part, but also the mental health, the psychosocial part of the research.
Thank you.
Great. So thank you very much. If we don't have any more questions, then I'll just thank you again, Xuedi, for the presentation. It was very, very interesting, and congratulations for the work that you and your team is conducting with Target Kids. It was very amazing. So thanks again, and thanks to everyone who attended today's presentation. We really appreciate it also. So thank you very much, and we'll see you next time. Thank you.
Thank you so much. Thank you for having me. Thank you so much.